I think it was
यूजुअली नहीं करता. अच्छा चलो कोई बात नहीं, we'll restart again. Again I hope कि एनोरेक्सिया की कुछ बेसिक्स क्लियर हो गई और इसकी मजीद साइकोपैथोलॉजी वगैरह कवर करते हैं. ये जितनी देर में लोग मजीद ज्वाइन करते हैं उतनी देर में मैं ये शेर सुना देता हूँ. परवीन शाकिर का शेर है, मेरे पास से जो गुजरा मेरा हाल तक ना पूछा. मेरे पास से जो गुजरा मेरा हाल तक ना पूछा, मैं कैसे मान जाऊं कि वो दूर जाके रोया. और अहमद फराज ने इसका जवाब दिया, तेरे पास से जो गुजरे तो जुनून में थे फराज, जब दूर जाके सोचा तो जार जार रोए. So that is the difference in perception of the people at one end and difference in the perception of the people at other end. Okay. I'm sorry. मैं दोबारा से इसको. Okay. So anorexia nervosa. Women with anorexia nervosa are frequently diagnosed with. Now, unfortunately, there was a break in the flow, so I would just like to continue with it again. That the comorbidity is high. So when you are seeing, oops, I hope I'm still there. Okay, yes, I'm still there. Okay, so comorbidity is high. So depression, OCD, phobias, panic disorder, alcoholism, personality disorders, and anorexia is common. And as I mentioned to you in the beginning, that anorexia is a symptom which presents to pediatricians, which presents to gastroenterologists, which presents to the physicians. And unfortunately, when they come to psychiatrists, their OCD or MDD is a bigger problem. So we start focusing there and we forget about anorexic symptoms or eliciting anorexia nervosa as a diagnosis. So next time, when you are seeing the people, try to understand that the comorbidity is high, but this diagnosis should be entertained if it is there. Men with anorexia nervosa are also likely to have a diagnosis of mood disorders. Bipolar disorder is very common. Schizophrenia common, and substance abuse. So anorexia nervosa, unfortunately, people have lots of problems with substance of abuse. So they will take weed, they will take opium, they will be alcoholics, men especially. And then you try to treat the main problem of substance abuse rather than treating the anorexia nervosa or a eating disorder. Unfortunately, this is common, but try to focus on the situation. And when you see that this is a disorder, then try to treat it as well. Physical changes in anorexia nervosa. Often people complain of low blood pressure. And when they complain about low blood pressure, we usually again say low blood pressure is not a disease. So probably they are having some somatization disorder or somatoform disorders or conversion disorders or any other disorders, but we won't consider anorexia as one of the diagnoses. Their heart rate slows. They have low pulse, so could be 60 or less than 60 or maybe around 60. Kidney and GI problems, पेशाब बार बार आता है, मैदा भूला हुआ महसूस होता है, गैस बनती है. Now we all changes these symptoms to major depressive disorder. Although the exact criteria for major depressive disorder is not fulfilled, but we still consider it as a major depressive disorder. Most of people present to us in our clinics with the symptoms of gas and gola formation in the stomach. Bone mass declines. So unfortunately, we don't go for bone mineral density. और विटामिन डी की गोलियां सारा पाकिस्तान खाता है, लेकिन हम बोन मास डेंसिटी असेस नहीं करते. Skin dries out, nails become brittle, hormone levels changes, mild anemia may occur, 90% of the females I see in my clinics, they have low hemoglobin. Now, either the criteria is wrong or there is something wrong with the laboratory. I don't know what it is actually, but I have hardly seen a woman with the normal hemoglobin level in my clinic. Majority of them, they are below it. Why is it? I don't know. EG abnormalities and neurological impairments and structural brain changes. This is common. Structural brain changes. If people who are suffering from anorexia nervosa, you will go for a CT or an MRI, there will be definite changes in them, which usually people reading it will say, oh, this is normal variation. But that normal variation correlated with the symptoms, we will definitely feel that it is a significant change. So ऐसे patients का MRI करवा के उसकी findings को देख लेना जरूरी है, and don't rely on the report only. See the film yourself and correlate it with your findings, clinical findings. Don't say that the radiologist, neuroradiologist had written age-related atrophic changes. Because when they say age-related atrophic changes, this doesn't seem to be okay for me. Age-related osteoarthritis, but even then we get the treatment for osteoarthritis. Then age-related changes, brain changes, people don't want to treat it. But if you ask me, that is significant for me because losing million of neurons because of that atrophy leads to emotional and other problems as well. So the lifetime prevalence of anorexia nervosa among females is approximately 0.5%. Now, this figure is low because exclusive anorexia nervosa is seen relatively less, but as a symptom, as a comorbidity, it is more. It is at least 10 times more frequent in women than in men. The incidence of anorexia nervosa appears to have increased in recent decades. So, पहले शायद इतना नहीं था, लेकिन now it is quite common. Course, anorexia nervosa typically begins in mid to late adolescence. सबसे ज्यादा common है teenagers में, और teenager लड़कों में भी और लड़कियों में भी. लड़कियों में ज्यादा, लड़कों में कम. और मैंने जैसे पहले कहा, most of these patients, they go to pediatricians where they are not treated the way it should be treated because the emotional component related to it is not addressed. So they do bounce back, they do get better because of the counseling and other the strategies and dietitian involvement and the counselor involvement, but it's not necessarily okay. So unfortunately, it's a problem. The onset of this disorder rarely occurs in females over age 40 years. 40 साल की उम्र के बाद आमतौर पे लोग इसके बारे में सोचना छोड़ देते हैं, या सेल्फ रिमिशन हो जाता है या बेहतर हो जाता है. ऑनसेट नहीं होगा, हाँ वर्सनिंग हो सकती है. Hospitalization may be required to restore weight and to address fluid and electrolyte imbalances in severe situation, and death most commonly results from starvation, suicide, or electrolyte imbalance. Now, suicide with anorexia nervosa probably is not as much as common, but comorbid with major depressive disorder, OCD, psychosis, and substance abuse, it is very frequent, and it is a complication which probably we miss because as a psychiatrist, people don't come to me. Prognosis. About 70% of the patients with anorexia eventually recovers. So people who are going to the pediatrician, people who are going to the gastroenterologist, people who are going to the physicians, they do bounce back either with the treatment provided or otherwise they do recover. Very rarely they end up with major symptomatology to a psychiatrist. Recovery often takes 6 to 7 years and relapses are common. Anorexia nervosa is life-threatening illness if not considered appropriately. And death rates are 10 times higher among individuals with disorders than among the general population, and twice as high as among individuals with other psychological disorders. So if it is comorbid with substance abuse, of course, then there is more morbidity. I hope I'm still there. Okay, I will go back. Death most often results from physical complications of the illness, for example, congestive heart failure, and from suicide if comorbid with other psychiatric morbidity. Now, coming to bulimia nervosa. What is bulimia nervosa? I initially said that it's a longer topic, so this will take a little bit more time, so bear with me. I will try to cover it up as quickly as possible. Bulimia is from a Greek word meaning ox hunger. ऐसे जैसा पेट, उर्दू में इसको translate कर लें. So actual bulimia word comes from ox hunger. This disorder involves episodes of rapid consumption of large amount of food followed by compensatory behavior such as vomiting, fasting, or excessive exercise to prevent weight gain. Now, again, you may feel that this is not common, but if you go to a gym in Pakistan, अगर आप में से किसी को इत्तेफाक हो और आप लोग शेप्स जाएं और शेप्स जाके उन लोगों को देखें जो वहां पे एक्सरसाइज कर रहे हैं, यू विल फील वो एक्सरसाइज करके निकलते हैं और पहला काम क्या करते हैं, वहां बैठ के कैफेटेरिया में जूस, सैंडविच, बर्गर्स और फ्राइज खाते हैं, राइट? Now this paradox of doing an exercise inside the gym and eating French fries sitting outside in the gym cafeteria with friends definitely leads to some cognitive distortions, and you should be able to understand that this is common. It's not as uncommon as it is considered. The DSM defines as a binge as eating when an excessive amount of food within less than 2 hours. So एक दफा मैंने कुछ खा लिए, 2 घंटे बाद मैं फिर कुछ खाऊंगा, 2 घंटे बाद मैं फिर कुछ खाऊंगा, and I will keep on eating. And if somebody around you does that, he is having bulimia. And bulimia, ox hunger, nervosa, emotional component associated with it. So bulimia nervosa is not diagnosed if the binge and purging occur only in the context of anorexia nervosa, and it's extreme weight loss. The diagnosis in such a case is anorexia nervosa binge eating purging type. अब ये थोड़ा सा कॉम्प्लिकेटेड है. सो अगर कोई शख्स का वेट कम है और वो खाता है और वो वॉमिट कर देता है और निकाल देता है और उसका BMI 17 से और 18 से कम है, तो फिर वो बुलिमिया नर्वोजा नहीं, वो एनोरेक्सिया नर्वोजा बिंज ईटिंग पर्जिंग टाइप कहलाएगा. This is again complex, but this is what is expected from you people to exactly and precisely say the diagnosis, especially in a written paper. This is how you have to write. One striking difference between anorexia and bulimia is weight loss. Individuals with anorexia nervosa lose tremendous amount of weight, whereas individuals with bulimia nervosa do not. So bulimia वाले का वजन ठीक होगा, BMI ठीक होगा, एनोरेक्सिया वाले का BMI कम होगा, वेट लॉस होगा. सो ये डिफरेंस है दोनों ईटिंग डिसऑर्डर्स में. अब डायग्नोस्टिक क्राइटेरिया फॉर बुलिमिया: a recurrent episode of binge eating. An episode of binge eating is characterized by both of the following. 1. Eating in a discrete period of time. 2 घंटे में खाना. A sense of lack of control over eating during the episode. So हर 2 घंटे बाद खाना मिलना चाहिए और खाना प्रॉपर होना चाहिए जिसमें क्वांटिटी अच्छी हो. That is binge eating disorder and bulimia nervosa. Recurrent inappropriate compensatory behavior in order to prevent weight gain, such as self-induced vomiting, misuse of laxative, diuretics, enema. ये मैंने एनोरेक्सिया में भी कवर किया था. वो क्राइटेरिया यहाँ पे भी है. The binge eating and inappropriate compensatory behavior both occur on an average at least twice a week for 3 months. हफ्ते में 2 दफा ऐसे एपिसोड जरूर हों और पिछले 3 महीने से ऐसे एपिसोड्स हो रहे हों तो हम डायग्नोसिस बुलीमिया नर्वोजा बना देते हैं. ओके, ये यूट्यूब पे एक गजल थी मेरी हसन की जो फिर कभी आपको सुनाएंगे, अभी टाइम नहीं. So diagnostic criteria for bulimia nervosa: self-evaluation is unduly influenced by body shape and weight, and disturbance does not exclusively during episodes of anorexia nervosa. So अगर BMI 17, 18 है, अगर periods miss हो रहे हैं, अगर weight expected weight से कम है, शेप बॉडी शेप की फिक्र है लेकिन वेट कम है, तो फिर बुलीमिया का डायग्नोसिस नहीं है. अगर वेट नॉर्मल है और ये एपिसोड्स हो रहे हैं और शेप की भी फिक्र है और खाने पीने की भी वाफिर मिकदार में एपिसोड्स हैं, then it is bulimia nervosa. So a little bit confusing, but try to understand what I'm saying. If there is still confusion, ask me a question. 2 types of bulimia, again, जैसे anorexia में बात की थी, purging type. During the current episodes of bulimia nervosa, the person has regularly engaged in self-induced vomiting, the misuse of laxative, diuretics, or enema. This is not the only situation. People can use other ways of losing weight as well, which I will definitely let you know in a short time. 2 types of bulimia nervosa: non-purging type. During the current episode of bulimia nervosa, the person has used other inappropriate compensatory behaviors such as fasting or excessive exercise, but has not regularly engaged in self-induced vomiting or misused of laxative and diuretics. So, एक उधर restrictive type थी, इधर non-purging type है. That is the difference between anorexia and bulimia, right? So you have to keep this thing in mind as well. In bulimia, binges typically occur in secret. They may be triggered by stress and the negative emotions. It arouses and continue until the person is uncomfortably full. वो जो पेट भरने की extreme situation है वो मौजूद होगी. Okay, I'm sorry, probably I missed a slide, so I'm going back. Foods that can be rapidly consumed, especially sweets such as ice cream. Again, अपने इर्द गिर्द नजर उठा के देखें, आपको घर में कोई एक खातून ऐसी जरूर नजर आएगी जिसको एक्सट्रीम एक वक्त एकदम अर्ज होगी, मैंने आइसक्रीम खानी है, और आइसक्रीम का पूरा प्याला एक वक्त में खत्म हो जाएगा. And the cake are usually part of the binge. आइसक्रीम की खास तौर पे बहुत क्रेविंग. A recent study found that women with bulimia nervosa were more likely to be binge while alone and during morning or afternoon. This is again a complication. आमतौर पे ये binge eating के दौरे जो हैं या सुबह के टाइम होते हैं नाश्ते पर, और या दोपहर को लंच ब्रेक्स में, आमतौर पे डिनर टाइमिंग्स में नहीं होते. इसकी रीजंस हैं. Avoiding a craved food one day was associated with binge episode the next morning. Other studies show that a binge is likely to occur after a negative social interaction or at least the perception of a negative social exchange. उसने मुझे ये क्यों कह दिया? This is complicated and this is problematic. उसने मुझे ये कह दिया इसलिए मैं पूरा आइसक्रीम का प्याला खा ली. Patients report that they lose control during a binge, even to the point of experiencing something akin to a dissociative state, perhaps losing awareness of their behavior or feeling that it is not really who they are and they are binging. They are actually usually ashamed of their acts and try to conceal them. और अक्सर हमारे पास जो डिसोसिएटिव के पेशेंट्स, जो मैंने सोमेटोफॉर्म में पहले भी बात किया, वो जो मरीज आते हैं, हिस्टेरिकल पेशेंट्स आते हैं, उनमें हम ये हिस्ट्री नहीं लेते. लेकिन अगर आप ये हिस्ट्री लें तो आपको सिग्निफिकेंट कोमॉर्बिडिटी इन द फॉर्म ऑफ बुलिमिया नर्वोसा मिलेगी, which is unfortunately common, but we don't, because we don't know, so we don't ask, and we don't ask, so we don't diagnose, and we don't treat. और इसीलिए मैंने पहले भी कई दफा ये बात की है, the outcome and the prognosis of the patient is compromised because you are not asking the questions that needs to be asked. You are not diagnosing it appropriately, and you miss things, so you don't get the required outcome and better results. After the binge is over, disgust, feelings of discomfort and fear of weight gain lead to the second step of bulimia nervosa, purging to attempt to undo the caloric effects of the binge. This is exactly like anorexia. Individuals with bulimia most often stick fingers down their throats to cause gagging. वो हमारे उस्ताद मोहतरम जो हैं वो जब हमें पढ़ाते थे तो वो कहते थे नकल्स देखें. जो लोग रिपीटेडली वॉमिट करते हैं उसमें ये नकल साइन होता है. ये वाइट और उस जो है ना एसिड की वजह से ये खराब हो जाते हैं. दांत देखें, उनमें बार बार वॉमिटिंग की वजह से एसिड लग लग के निशान सफेद सफेद चटाक पड़ जाते हैं. Those are two very significant clinical signs. People who induce vomiting, they have white knuckles and they have teeth which have white spots because of the acid of the stomach. When they throw out, they have these signs. So do look for these signs. Laxatives and diuretic abuse as well as fasting and exercising is common. Okay. The DSM diagnosis of bulimia nervosa requires that the episodes of binging and purging occur at least twice a week for 3 months, which is the same for anorexia as well. Is twice a week a well-established cutoff point? Now, this is tricky. A continuum of severity rather than a sharp distinction. So, अगर कोई शख्स मेरे आगे प्रेजेंट होता है, वो महीने में भी एक दफा ऐसे एपिसोड में इन्वॉल्व है, I will still consider the emotional correlation with the presentation and definitely would like to reevaluate it. Okay, so moving further, I will just skip few slides because probably there is some repetition. Physical changes in bulimia. Menstrual irregularities, amenorrhea can occur. BMI is either normal or it is more. And how to calculate the BMI, I have already told you, so I won't repeat it. There is potassium depletion. So if you go for electrolyte changes, then you will be able to find it. Physical changes, I have already mentioned to you. The salivary glands may be swollen and there may be history of stomach ulcers. So again, as I mentioned to you, people mostly go to gastroenterologists rather coming to psychiatrists. Women are more common than men, and lifetime prevalence and course, again, it definitely recovers. 4 से 7 साल तक रहेगा, ठीक हो जाएगा और episode में relapses के chances exist करेंगे, which I have mentioned already. 70% do recover, so there is no difference in that. आओ चुप की जुबान में नासिर इतनी बातें करें कि थक जाएं. So मैं बातें कर करके थक गया हूं, मैं चुप की जुबान नहीं बोल रहा. So the key point, one striking difference between anorexia and bulimia is weight loss. Individuals with anorexia nervosa lose a tremendous amount of weight, whereas individuals with bulimia nervosa do not. That is the major difference between the two. Etiology. Now, trend in the families, genetic basis, and serotonin abnormalities. All three are considered to be the etiology. Serotonin may play a role in bulimia, with the studies finding a decrease in serotonin metabolites, and this is one of the reasons why fluoxetine was launched. This is the only drug approved by FDA for bulimia nervosa because there was some evidence of serotonin involvement in it. Genetic factors, dopamine may play a role in restrained eating disorders. So there are biological components, and अगर कोई अगले सेशन में न्यूरोबायोलॉजी ऑफ साइकियाट्रिक डिसऑर्डर्स पढ़ाया दोबारा मैंने, जो मैं एक दफा पहले कवर करा चुका हूं, तो मैं ये दोबारा कवर करवा दूंगा। सोशल कल्चरल स्टैंडर्ड्स फेवर अ थिनर शेप, जो कि आजकल बहुत इन है, और बट मैं अभी रिसेंटली एक पाकिस्तानी गाना सुन रहा था और मैं उसको देख रहा था, सो विजुअली, और मैं देख रहा था कि वहां पे अगेन वो ट्रेंड अब पतला होने का नहीं रह गया जो अभी भी कुछ और मुल्कों में। सो आई डोंट नो, आई मे बी रॉन्ग, इट इज जस्ट माय ऑब्जर्वेशन। Psychological level, the parent-child relationship and personality characteristics. So most of the time we diagnose them as a borderline personality disorder and we fail to understand they could be having comorbid anorexia nervosa. Food becomes a symbol of this failed relationship. Daughter's binging and purging represents the conflict, and need for the mother and the desire to reject it. सो तुम मोटी लग रही हो, तुम सबके सामने ना आया करो, कपड़े ठीक तरह पहनो, दुपट्टा सही तरह लो, अपने आप को पीछे से छुपाओ, ऐसे चादर लो कि तुम्हारे बटक्स नजर ना आए, ऐसे दुपट्टा लो कि तुम्हारे सामने वाला हिस्सा चेस्ट नजर ना आए. And these common statements definitely leads to more of the problems, psychological and low self-esteem, and leading to these disorders. Psychological levels high in neuroticism and perfectionism, and low in self-esteem, and report being abused as children. So this child abuse is a common problem at the back. Or I don't know, again I will say the same, we don't ask about the child abuse. If you ask, you will know. When you don't ask, you don't know. Fear of being fat and body image distortions, and we have talked about it throughout our presentations. A negative effect in stress, precipitate binges, creates anxiety, relieved by purging. Okay, now one more thing before I end up. Psychological treatment, as we have talked about it earlier, we have to control the diet. We have to make sure that they eat properly. Then we try to develop the normal eating patterns, 3 meals a day, some snacks in between. We also try to do the cognitive behavior therapy and interpersonal therapy, and again some behavior management strategies जो मैंने cover करवाई हैं. So one intervention that is sometimes used in the cognitive behavior treatment approach asks the patient to bring small amounts of forbidden food, to eat them during those sessions, and relaxation over. So the exposure and response prevention is another good type of the treatment which can be provided to these patients, and assertive skills of when people are criticizing, how to say no when it should be said no. So I won't go into that details. And SSRI's treatment I have mentioned to you earlier as well. This is the last few slides that I want to definitely focus on, which unfortunately I believe are more important because we don't see clearly anorexia and bulimia in our clinics as much as it should be there, because people have still stigmatized. Eating disorders not otherwise specified. For females, all of the criteria for anorexia nervosa are met except that the individual has regular menses. And all of the criteria for anorexia nervosa are met except that despite significant weight loss, the individual's current weight is in normal range. ये जो इम्पोर्टेंट पैरामीटर है, ये जरा देखें कि जो डायग्नोस्टिक क्राइटेरिया है एनोरेक्सिया नर्वोसा का और बुलिमिया का, वो जब कंप्लीटली फुलफिल नहीं होता, लेकिन उसके कुछ पैरामीटर्स फुलफिल हो रहे होते हैं, एंड व्हेन यू ट्राई टू असेस देम, दे आर हैविंग सम BMI less, some emotional problems, some appetite and weight issues, low self-esteem, but because they are diagnosed as dissociative or conversion disorder or borderline personality disorder or some other disorder, major psychiatric morbidity, we don't focus on these things, which unfortunately creates the problem. So just make sure that you would be able to diagnose it. आखिर में जाते जाते ये मेरी हसन साहब ने एक गजल गाई थी अहमद फराज की, और बहुत खूब गाई थी, और उसके बाद इसको कुछ और लोगों ने भी, नए लोगों ने गाया। इसका सिर्फ एक शेर अब तो सुनाऊंगा। अब तक दिल खुशफहम को तुझसे हैं उम्मीदें, ये आखिरी शम्मे भी बुझाने के लिए आ. So the target is that try to evaluate, try to assess, try to manage. So मैंने symptomatology कवर की है, मैंने etiology कवर की है, मैंने pathology कवर की है, और मैंने treatment strategies briefly आपको बताई हैं. Any questions? I'll be most happy to respond to it.